Session 14 is about medications. We provide a high level overview of medication prescribing and dispensing. We also dig into commonly encountered issues related to medication adherence and primary care.
What is a medical doctor without prescribing medicines? Let's start by talking about prescribing habits and how doctors think about what medicines they prescribe. The first thing to talk about is medical momentum. What that means is what a doctor trains to do is what they end up doing the rest of their life. For example, in a patient with hypertension or high blood pressure, if in medical school I'm taught to prescribe lisinopril and in residency that's reinforced, then for the rest of my career, anytime I see a patient with hypertension, I will think lisinopril, unless a major bulletin comes out that lisinopril kills people. This happens across pretty much every complaint or symptom. As a doctor encounters new diseases or new complaints, they might try a new medicine, or maybe something they used previously didn't really work and they'll try something new, but then they enter into this medical momentum again. And that one thing that worked once, they tend to do over and over and over and over again. This is very similar in psychology to the opening of Freakonomics, where commuters would go a certain way to the subway station until there was construction in the way and people would change their route. And when the construction went away, a lot of people stuck to the new route because it was actually more efficient. Doctors may actually continue to prescribe a certain medicine that may not work as well as another medicine simply because they've always been doing it and it's worked well enough. And then when you zoom out this concept to the aggregate, you find that different pockets of the country actually have prescribing culture. That is, for example, in the Midwest, they might prescribe a certain muscle relaxant to everybody for back pain that doctors on the East Coast may never prescribe or may not have even heard of. And doctors on the East Coast might prescribe a certain cream or ointment for certain rashes that on the West Coast they feel like is overkill or just the wrong medicine altogether. We talked in a previous module about experience-based versus evidence-based medicine. And while evidence-based medicine provides certain frameworks, experience-based medicine really drives a lot of the day-to-day prescribing habits of most doctors. And medical momentum is one of the larger contributors to why experience-based medicine sometimes overtakes evidence-based medicine. The next decision doctors make is how much medicine to prescribe. It may seem simple, but there is actually some thought to this. Or in terms of something acute, like antibiotics, there's generally guidelines to how much works without creating antibiotic resistance. But even this is questionable. If you've noticed, a lot of antibiotic courses are 7 days. Why is that? The main reason is because it's a week. Weeks are easy to remember. There's some pushback now about shortening antibiotic courses for other diseases. For chronic medicines, there's the decision of 30 days versus 90 days versus something else. And the quantity really depends on several factors. One, if this is a medicine that might need to be titrated up, for example, you're starting, let's say, an antidepressant, which usually takes some time to ramp up, and patients generally aren't started at the highest dose due to side effects. You start low, and it just depends on how well the patient handles the side effects or depends on how well they respond to the medicine. You might want to do a shorter course based on how fast you think they'll ramp up, or a longer course if you think they'll be on this amount for a certain amount of time. But then getting to chronic diseases, for example, blood pressure, there's the decision of 30 versus 90 days. Sometimes it's based on cost and convenience, and sometimes it's used as a carrot or stick, depending on how you think about it. If you have a patient who you know is really bad at following up unless you keep their medicines from them, which is, I guess, a harsher way to say it, but you give them a smaller quantity to ensure that when they start running out, they call the office and come back in to get a refill so you can check their labs, check their vitals, or whatever you need to do. One of the liabilities is if you give them a longer course of medicine and then they don't follow up, their condition worsens or they get some side effect from the medicine, then it looks bad on you. The next consideration is how many refills to give. And this thinking is pretty similar to the quantity thinking, minus the whole bit about antibiotics and the acute stuff. But if a patient has been on a same drug for a long time, has had no changes, it makes sense to give refills for the entire year. If you're actively managing, then maybe no refills or just a couple refills if life situations are happening and you want to make sure the patient doesn't run out of medicines. One interesting new development is using telehealth for refills. Previously, especially right after COVID, most telehealth platforms were just doing urgent care, easy things that you can diagnose over the phone or video with a short course prescription like an antibiotic or steroid. But with Amazon Clinic, one of the things they're doing that's unique is allowing for med refill. If you can show certain documentation and proof of the medication, they'll actually do a virtual visit and refill your medicine. And we'll see how far they push the envelope on that issue. And then finally is the pharmacy. So once you have the medicine chosen, how much you want to give, and how frequently you'll allow the patient to go back and get it again and again, where do you send it? Most patients will generally have a good idea, especially if you have continuity with the patient, if they're a regular primary care patient. But things change. One of the bigger changes is insurance contracts. When CVS and Aetna merged, all of a sudden Aetna plans stopped covering medicines at other places and preferred CVS. Doing some part-time work at the urgent cares, I will frequently go over pharmacy with the patient and say, "Oh, do you want this one?" They said, "Oh, no, my insurance just changed. I can't send my medicines to XYZ pharmacy anymore. It has to go to another one." Another consideration in terms of pharmacy, especially for acute visits, is the pharmacy open. There are fewer and fewer, at least in the suburbs of Virginia where I am, 24-hour pharmacies. If a patient sees you later in the evening or messages you at the after hours number and there's something that they need in the evening, now you have to figure out where the 24-hour pharmacy is. This is from my urgent care experience where the patient will come near closing, they request the medicine be sent to a certain pharmacy, and then they go all the way to the pharmacy only to find that it's closed and they don't know where to go next. Which brings me to my next point. There's surprisingly little lateral movement between pharmacies. When you send a medicine to a pharmacy, it's pretty hard to cancel it. As far as I know, most EMRs I've used, you can't really cancel in the system because once it's sent to the pharmacy, it's a different system. So in order to cancel something or to clarify, you actually have to pick up the phone and talk to the pharmacist in order to get rid of the medicine. And I'm sure there's startups or tech or something out there that's fixing this issue, but it's still a pretty manual process. The final thing under prescribing is just a special mention of controlled substances. When you prescribe a controlled substance, number one, patient has to have some sort of pain contract saying they're not going to get pain medicines anywhere else. Or if you're emergency room or urgent care setting, nowadays, prescription opiates or controlled substances, they'll only prescribe you a very small amount depending on the state and how much is allowable per state legislation. And most states have a PMP or a prescription monitoring program where doctors are required to reconcile what meds they've gotten from everywhere else in the state to make sure they're not hospital or doctor hopping and that what you're giving them is appropriate at the appropriate time. The next topic is dispensing. Dispensing is state dependent in terms of licensure. So right now, the state of Texas does not allow doctors to dispense. Whereas in the state of Virginia, doctors are allowed to dispense, but it's not regulated by the Board of Medicine. It's actually regulated by the Board of Pharmacy. In addition to getting a medical license through the Board of Medicine, you also have to get a dispensing provider license from the Board of Pharmacy. In urgent care, there are certain urgent cares that will dispense. There are some patients where cost is a big consideration and they would rather have it sent to a pharmacy rather than pick it up at the urgent care, even if it only saves them maybe a couple dollars. Whereas other people, they will pay 2 to 3x for a medicine just to pick it up at the urgent care pharmacy so they don't have to drive and get it. It's pretty interesting to see the different types of patient populations there. Value-based practices like Medicare Advantage or direct primary care tend to do a lot more dispensing than fee-for-service offices. And part of that is being able to get wholesale prices and passing those savings off to patients. It's a big selling point for direct primary care practices, and it's a big cost savings for Medicare Advantage companies or practices. The final mention for this session is medication adherence. That's always a hot topic for doctors. Amongst doctors, there's a saying that the best medicine for a patient is one that they will take. There are a lot of considerations to this saying. One of the issues with med adherence is patients don't really understand what medicines are for or how they work. And there's an example that is more common than we would hope, which is patients who have chronic conditions will only take their medicines until they feel like they don't need it. Blood pressure is an interesting one, and there's different scenarios for blood pressure. One scenario is, oh, I have high blood pressure and I know it because I get a headache. And so when I get a headache, I'll take my blood pressure medicine until I don't feel a headache, and then I'll stop it until my next headache, which hopefully most of you know that's not really how blood pressure medicine works. The other scenario is a communication problem. Let's say a patient shows up at the urgent care and at triage, they're asked, do you have any high blood pressure? And the patient says no. But then the doctor does the medication reconciliation and they say, oh, hey, you're on these 3 blood pressure medicines. You told the triage nurse that you didn't have high blood pressure. And the patient then says, oh, I did have high blood pressure, but now I'm on medicine, so I don't have high blood pressure, which also is not how that works. The other issue comes in with the patient and their bag of meds. We talked about this patient archetype earlier. When doctors ask the patient, hey, are you taking your metformin? Are you taking your amlodipine? A lot of times patient will say back to us, oh, is it that little white pill or is it the bigger blue pill? Full disclosure, doctors don't know what that means. Depending on the manufacturer, the pharmacy, the pills could be all different shapes and sizes, and it's generally not something we learn. So a lot of med adherence challenges begin at patient education and patient understanding of their own medicines. Medication adherence is such a big issue that there are studies that suggest that 50% of people who have chronic conditions have poor or no med adherence, which of course then downstream causes a lot of issues when their chronic conditions exacerbate. In terms of the fill history, there are services out there like SureScripts, and if you are connected to SureScripts, you can see the fill history. And for the value-based like ACOs and Medicare Advantage, there are more companies in tech that are now connecting to SureScripts and other pharmacy-based systems to allow the doctors and the prescribers to actually know if their patients are filling their meds, and if so, if they're filling them at the right times. One way you can check for med adherence is if your patient is actually picking up their meds when they're supposed to. If you only give them 30 days of medicines and they don't pick it up for 50 days, there's a good chance they probably missed it somewhere. And the final mention in terms of med adherence is cost consideration. One thing that, especially early in practice, in med school and residency, you learn that certain diseases require certain medicines. And of course, there's the whole medical momentum and all of that. But one thing that is not taught nearly as much is the cost. In residency, I would prescribe a medicine, set a 3-month follow-up. The patient would come back. I say, hey, how's the medicine going? Any side effects? And they say, I never picked it up. I got to the pharmacy and it was X hundred dollars and that was too expensive. And especially in the fee for service world where the patient may not be able to contact you as freely and there's a longer follow up, this creates all sorts of problems. And so it's probably a good idea for doctors to have some sort of understanding of the cost. And generally, later in practice, when you run into this situation enough, you start to learn what medicines cost and how to prescribe a little more smarter and hopefully understand the financial situation of your patient a little better. There are now services, GoodRx, having been around for a while, which helps you guesstimate what a medicine might cost. And it's something that I recommend my patients check alongside their insurance because I've had fully insured patients with quote good insurance who end up going to the pharmacy. They tell me, hey, I picked up this med, it was this much, it's fine. And I'll go on GoodRx and it's actually cheaper. And of course, Mark Cuban is doing his cost plus drug thing. The other places where costs can be a little more fluid is local pharmacies versus the big chain pharmacies. But either way, outside of the basic routine, relatively cheap medicines, there are a lot of cost considerations. And again, going back to that saying, the most effective medicine is the one that the patient will take. Cost consideration is one of the higher priorities in terms of thinking about what to prescribe to a patient.
To summarize, we provided you with our insights on medication prescribing and dispensing. We also gave you our perspective on medication adherence through the lens of primary care. This concludes session 14.